And now it's my esteemed privilege to introduce our grand round speaker, Dr. Carolyn Sufrin. When she walked in today, she said today felt like a homecoming of sorts, and we're really thrilled to welcome her back. For those of you who don't know, Dr. Sufrin is a medical anthropologist and an OBGYN specializing in complex family planning at Johns Hopkins University, where she is an associate professor in the Department of Gynecology and Obstetrics, and associate director for the Center for Medical Humanities and Social Medicine at the School of Medicine. She also holds appointments at the Berman Institute of Bioethics and in Health, Behavior, and Society at the Johns Hopkins Bloomberg School of Public Health. She obtained her undergraduate degree in anthropology and chemistry from Amherst College, a master's degree in social anthropology from Harvard University, and her medical degree from Johns Hopkins University. After her OBGYN residency at the University of Pittsburgh, she came to UCSF, where she completed a fellowship in complex family planning and also obtained her PhD in medical anthropology. Before joining the Johns Hopkins faculty, she was an assistant professor in our department. And while in San Francisco, she started a women's health clinic at the San Francisco County Jail, which continues to provide care today. She has worked extensively on reproductive health issues affecting incarcerated women, from providing clinical care in jail to research, policy, and advocacy. Her work is situated at the intersection of reproductive justice, healthcare, and mass incarceration, which she examines in her book, Jail Care: Finding the Safety Net for Women Behind Bars. We are really thrilled to have her join us today. For our learners and our faculty, she set the powerful example of using research as a tool for advocacy, as she has done in her efforts to improve reproductive health care for incarcerated individuals and to contribute to conversations around reform of the carceral system. Please join me in welcoming Dr. Sufrin.
Oh, this really is a homecoming. UCSF is really where I got my start in so many ways. And I'm going to tell you a little about some of those ways. I've no disclosures. These are my CME learning objectives. And most of you know this guy, Dr. Philip Darney. And although this picture maybe was not taken in 2006, I first met Dr. Darney in 2006 when I came to UCSF to interview for Family Planning Fellowship. And like some of you, I was at the beginning of my fourth year. I was so excited about family planning. This is what I had gone to residency for and or OBGYN for and what I wanted to do. And I really wanted to come to UCSF. It was and still is the Mecca for family planning training. So I really wanted to impress him. So during the interview, he looked at my very thin CV and he noticed my resident research project, which was about access to contraception and abortion for incarcerated women. And this was, to me at the time, this was just my resident research project, it kept me a little engaged, checked the box for the requirement of doing research, but, I didn't really think much of it other than when I got to Family Planning Fellowship, then life would begin. But Dr. Darney, always an astute mentor, turned to me and said, wow, reproductive health care for incarcerated women. That's really great that that's going to be your niche. And as a resident, I had no time to think about my niche, but I really wanted to impress him. So I nodded my head vigorously and I said, oh yes, Dr. Darney, that will be my niche. And of course, I'm pleased to say many years later that he was very right. But in that moment, in 2006, if you did a search of me on PubMed, 0 publications. I have no idea how I ended up matching here, but thankfully it worked out. And although nowadays I have many more publications, it's not maybe as many as some of the people in this department, but this is over the course of almost 20 years now from that moment when Dr. Darney could see into the future and know what my niche would be. My resident research project actually did set me on a course for the rest of my career. No pressure to the chief residents. It wasn't intended, but sometimes when you say yes to things and follow, I don't mean to sound cheesy, but follow your passions, follow the things that compel you in your heart, then sometimes they can take you to a place that you realize this is what my niche was meant to be. So since then, obviously, Dr. Darney was right, and it has become my niche. I've conducted lots of different types of research, all related to reproductive health care and reproductive health outcomes for incarcerated people, from contraception access, lactation, access to medications for opioid use disorder in pregnancy, COVID behind bars, and many other things. And I could spend hours talking about any one of these issues, but today I'm going to highlight mostly my research on abortion and also some of my research on pregnancy outcomes, including the little that we know about maternal mortality. And throughout, as I highlight some of this research, I'm going to weave through the stories of how I generated these research questions, because I think it's important for the residents and other young researchers to understand some of the affective dimensions, what compels you to do certain research, and the stories of what get us to research that you all see neatly packaged into a publication in a journal. But there's a lot more that leads up to that neatly packaged point. And so also throughout, I'm going to highlight the importance of two things that have really, really driven me and guided me throughout. And those two things are recognizing, as you've already heard from Dr. Whetstone, what I've lived my research through is seeing research not only as a curiosity and a desire to learn more, but as a tool for social change and advocacy, doing research with a purpose. And you have so many examples and models of that here at UCSF. And that's part of where that was cultivated for me as well. And the other is to engage in critique. Now, by critique, I don't mean being negative and criticizing. I mean critique in the sense of what French philosopher Michel Foucault defined as critique. Did anyone major in like a social science or philosophy in college and read any Foucault in their lives? Okay, yes. What's that? Anthropology, great. All right, so Foucault, yes, there's a lot to him. He's not perfect in any ways, but he's a very highly influential social theorist. And his definition of critique, I think, is so important and so salient that it has guided me in my work. And he said, a critique does not consist in saying that things aren't good the way they are. It consists in seeing on just what type of assumptions, of familiar notions, of established and unexamined ways of thinking the accepted practices are based. To do criticism is to make harder those acts which are now too easy. So critique is about not being negative, but about questioning assumptions and the things that are like, wait, did I just miss something? Or no, you probably didn't. It's missing in the broader sphere of knowledge. So I told you about my origin story of my niche, but and how Phil Darney and UCSF played a central role in that. But even before I came to UCSF and how I got to that point of having at least a bullet point describing my resident research project was when I was an intern at Magee Women's Hospital, and I got called to a delivery room one night. And, you know, as an intern, I was just like, okay, got to run from triage to the delivery. Don't drop the baby. Don't drop the baby. Then I walked into the room, and the woman who was about to push was shackled to the bed. This is not something I ever imagined. No one had ever talked about this in medical school. And we just don't think of someone giving birth as also potentially being shackled. And in that moment, I had so many questions and so many distressing, unsettling thoughts. Of course, much more so for the birthing person themselves, but for me, it was very unnerving, unsettling, and a little traumatizing. Again, not as much as the person giving birth. And I wondered, why is she shackled? Why is she incarcerated? Does it matter? Can I do anything to ask the guard to remove those? And I should have, but I did not. And I wondered about my own complicity in that moment. And from that moment on, as well as from my postpartum rounding the next morning at 3 a.m. and asking her about contraception, I wondered, what does contraception access look like for this person? I'm writing a prescription for the ring, which she decided she wanted, but is that going to even happen? So is that moment, that clinical experience as an intern, that opened up a whole set of questions and caused me to question a lot of assumptions. So then several years later, and when I got here to UCSF, I sought out the opportunity to work at the San Francisco jail, although it started as my research project, my fellowship research project to explore access to emergency contraception for newly arrested people. And in the course of trying to set up the ability to do research, the medical director of the jail said, well, how about doing some clinical work here? And I said, oh, okay, sure, that's fine. That'll be my way of giving back. But of course, I got so much more out of the experience, I think, than I brought to the jail. But it was profoundly compelling and troubling and interesting and rewarding in a lot of ways, and also induced a lot of anger, and not at necessarily at individuals, but at what I started to learn about mass incarceration in our society. And so what I began to learn as I started to provide medical care at the jail is that it was full of contradictions. What does it mean to care in a space of punishment? And I soon learned that incarcerated people are the only people in our country with a constitutional right to health care. For some people, jail was the only place they accessed health care. And my assumptions about guards being all categorically cruel and traumatizing and harmful were not always true. And assumptions about medical caregivers always being compassionate and patient-centered were also not always true. And so again, I was questioning a lot of assumptions. So I started to learn a little bit about mass incarceration and how it affects women. And I say women here because all of the statistics that we know about people who are incarcerated report them as women or as females. But of course, I acknowledge that there are people of various gender identities who are incarcerated. So there are a lot of intersections between mass incarceration and fundamentally between all forms of racism, structural oppression, and reproduction. We can look at just some of the statistics and the numbers. On any given day, the most recent estimates are that there are over 180,000 women behind bars in the US, in the majority of them in local jails, some in state prisons and federal prisons. Most of them are of reproductive age. And so the health concerns that our patients between 18 and 45 who are in the community have are similar ones to people who are behind bars. And critically, most of the women who are incarcerated in our country are mothers and the primary caregivers to young children. So the disruption of communities and families that happens when you incarcerate a mother and a woman are profound and have intergenerational impacts. The racial disparities are profound and are easy to see on a graph, but they don't tell the full story of why and how these exist. But we know that Black women are 2 times more likely to be incarcerated than white women, and American Indian and Alaska Native, as it's reported, they are 4 times more likely to be incarcerated than white women. And all of these statistics and these trends in who is incarcerated, there's a history, there are policies, there are forms of racism that have produced these disparities, what we see as disparities. And what I mean by these intersections between all of these forms of oppression and reproduction is that these policies are shaped by the fact that over the last 40 years, our country has come to rely on incarceration as a means of social, economic, and racialized control in a very punitive ways, and in ways that diverge significantly from the ways our society utilized incarceration previously, when there were very few people who were behind bars, and not that it was a golden age necessarily, or good necessarily, but it was just a very different strategy of thinking, who do we need to remove from society and why. But that all changed through a series of calculated political and racialized policies, which I could spend all day talking about. Some of them relate to the so-called war on drugs, but they're much deeper than that and have a longer legacy in policies of trying to quell the civil rights movement in the 60s and 70s and beyond. And this story of mass incarceration and its racialized dimensions, has played out in very particular, distinct ways for mothers, for people who are parents and people with the capacity to be pregnant, especially Black mothers, and in ways that are inextricably linked to other systems, discriminatory and harmful systems and policies that, for instance, criminalize substance use in pregnancy, and the ways that those policies have been differentially applied to Black mothers and Black families. But it's also, as Dorothy Roberts and others have written about extensively, it also is related to systems that some people often think of as trying to protect children, sometimes called the Child Protective Services system, but what Dorothy Roberts and others call the family policing system. That such systems have targeted, surveilled, and limited the possibilities in very distinct ways for Black mothers and Black families, and in ways that have a pipeline from the family policing system into incarceration in ways that are very racially disparate. And this has eroded and harmed our entire society, and done so in particularly unique ways for Black communities. So when we now think about how that relates to some health conditions that are also prevalent in this population, so incarcerated women, we know that they have very high rates of mental health diagnoses. We know that they have high rates of substance use disorders. We know that most of them have experienced a variety of forms of trauma, whether it's sexual trauma, whether it's physical, emotional, whether it's the trauma of precarity and marginalization. And all of these are no accident. The people that our society chooses to arrest and incarcerate, the issues are more broadly related to our short-sightedness and our lack of imagination in investing in real ways that we can actually address these problems of trauma and mental health diagnoses as well. And most incarcerated women have lives that are affected by adverse social and structural determinants of health, some of which I've already mentioned, but that also includes poverty, lack of access to employment opportunities, unstable housing, and a variety of other factors as well. And so when we think about all of these factors that have contributed to racial inequities and racialized policing and incarceration, when we then start to think about how this lines up with maternal health more broadly in our society, it becomes really hard to ignore the parallels in those bar graphs and the disparities that we know exist in maternal mortality, and that also have similar upstream causes to the disparities in female incarceration rates. Mental health conditions, we know, are the leading cause of pregnancy-related deaths. And so 70% of incarcerated women have mental health diagnoses and also have substance use disorders. Again, it becomes hard to ignore the fact that maybe there is a connection. But we actually, as I'll continue to talk about, we don't know very much about those connections. But it becomes imperative that we start to question this, again, question the assumptions. What do we know and what do we not know? So I mentioned as I started to work in the San Francisco jail and became confronted with all these contradictions, I started to learn about this this very peculiar fact that incarcerated individuals have a constitutional right to healthcare, and in fact are the only people in our country with a constitutional right to healthcare. So let that sink in for a moment. You get arrested, you go into a prison or jail, and you lose most of your rights, but you gain this right to healthcare. And this comes from a landmark Supreme Court, a landmark in my field, but a Supreme Court case in 1976, where an incarcerated individual alleged he didn't get adequate healthcare. The Supreme Court says, actually, you did, but they used it as a platform to say that the deliberate indifference to the serious medical needs of prisoners is cruel and unusual punishment. And so since that moment, prisons and jails and other institutions of incarceration have been constitutionally required to provide healthcare. However, it didn't come with any set of mandatory standards or any oversight organization that would ensure prisons and jails would do this. And so you get tremendous discretion and variability in terms of how services are delivered, what is considered a serious medical need. There's no required standardization. And although there is an accrediting organization, the National Commission on Correctional Healthcare, that has standards and facilities can choose to become accredited and meet their standards. It's totally optional, and only a third of jails and prisons are accredited. Highly variable, what is routinely available and what can be requested, and what's categorically not available, what's available on-site, off-site, who pays for it is highly variable. But one thing that is consistent is that Medicaid does not change, although some recent policy changes, including in California, are starting to change that. But when Medicaid was created, there is a clause in there. It is actually called the Inmate Exclusion Clause that specifically says Medicaid and Medicare cannot be used to fund care for people who are incarcerated. Some facilities require a co-payment for patients to see a clinician. And then there are a lot of facilities that contract out their healthcare services to private corporations who are motivated by providing care for as cheaply as possible, so they maximize the amount that they get to keep from their contracted arrangement. When it comes to perinatal care, highly variable. You have the San Francisco County Jail, where you have robust care provided by an excellent women's health nurse practitioner, and Dr. Seidman and all the residents who come there, but it's highly variable. Also, one thing that's really important to keep in mind, especially as I start to make the connections again to maternal health, maternal morbidity and mortality, is that when you're incarcerated, you can't just go to triage. You can't call up your midwife or your provider if you're having an issue. You rely on a custody officer as your gatekeeper to medical care. They are the ones who are triaging you, and they are not medically trained, right? And you may have a range. You may have some, and I've met plenty of officers who say, oh, a pregnant person sneezes, I'm calling medical. And then many others who ignore florid, obvious labor and people give birth in their jail cells. So there's a lot of variability. There's a lot of isolation if you're pregnant and incarcerated, fear, uncertainty about what's going to happen to you and your safety, what's going to happen to your child. You may be shackled during pregnancy or during childbirth, and you are most likely going to be immediately separated from your newborn when you go back to the facility, when you're discharged from the hospital. And then if you're pregnant and you need an abortion, and I say need for all indications, all abortions are indicated, and anyone who has decided they need one needs one. But if you're incarcerated, what does that look like? So the summary, when anyone asks me, what does healthcare for incarcerated people look like? All I can say is it depends. So now talking a little bit more about abortion care for people experiencing incarceration. This was actually one of the things that motivated me from the beginning. And as I transitioned into fellowship and Dr. Darney nudged me along my niche, I wanted to study abortion care. My resident research project showed, when I surveyed carceral health providers across the country, showed that abortion access was inconsistent, surprise, surprise. And so this was in 2008, 2007, 2008. This is when the Turnaway study was getting started. And I thought, whoa, we need to do a Turnaway study in prison. What happens when incarcerated people who need abortions are prevented from getting them simply because, well, or complexly because they are incarcerated? So I talked to Diana and Diana Green Foster, and I said, I want to do a Turnaway study in prison. And she said, oh, that's really interesting. So how many abortions happen each year to incarcerated people? And this was a very Foucauldian critique moment. Like, before jumping into what happens to them, well, wait, like, does anyone get one? And to counter, not to counter, but to continue that Foucauldian critique and questioning, I said, oh my goodness, we don't even know how many pregnant individuals are behind bars. We don't know how many give birth, have miscarriages, let alone abortions and other outcomes. We had no idea. This was like 2008. And even though I was citing some reports from the Department of Justice, 6 to 10% of incarcerated women are pregnant, when I looked at the footnote, it came from nowhere, basically, like no validated, legitimate source. And I and the few other people studying this were replicating that. So I began to wonder, and I asked, wait, okay, someone I don't know, but someone must be collecting these data. Turns out, no, the National Vital Statistics System that collects birth and death information, nobody was capturing incarceration status of the birthing person. PRAMS, the Pregnancy Risk Assessment Monitoring System, they now ask a question about incarceration of either parent during the pregnancy, but that could be the biologic father or the mother. The Bureau of Justice Statistics, which is a branch of DOJ, which collects annual statistics about incarcerated people, nothing about pregnancy. So nobody was counting these people. And when they don't get counted, it makes it easy to say, oh, they don't exist, and therefore we don't need to invest in their healthcare or anything else. So for my next research project, when I sadly left UCSF and set up shop at Johns Hopkins, I was able to get an SFP Junior Investigator Award because I was motivated by abortion, but I also knew the NIH potentially might care about this issue with all the other pregnancy outcomes as well. And so I conducted a study where we enrolled 22 state departments of corrections, all federal prisons, which literally took a letter, maybe not an act of Congress, but a letter from Congress to be able to do, as well as 6 jails, including the 5 largest jails. And they reported to our study database on a monthly basis for 1 year. And we collected a lot of data, but these were the main outcomes. And honestly, the most striking finding is that pregnant people behind bars exist. They do exist. We found that at our prisons, there were nearly 1,400 admissions of pregnant individuals. At our 6 jails, there were like 3,000 jails. We only studied 6 of them. There were 1,600. And so we extrapolated from that approximately 58,000 admissions of pregnant people to prisons and jails each year. That is not a small number. Now, you just need one in my book to be able to require to provide care. And of all the pregnancies that ended in the prisons, only 11 were abortions, 1%. And that is much lower than the 18% abortion ratio that existed at the time. Now, we looked at policies in our study as well, and we found that many prisons did have a policy that allowed abortion access, but some of them didn't. And at the time, Estelle versus Gamble, that's the healthcare case, that precedent established that incarcerated individuals retain their constitutional right to abortion. So at the time, they still had a right to abortion. Now it's contingent on the state abortion law. But still, there were several facilities in our study that did not allow abortion by official written policy. And there were even some prisons in abortion supportive states that only allowed it in the first trimester, which was out of step with state law. But they can get away with it because there's no oversight. And so from this study, okay, there are very few abortions. There are some restrictive abortion policies. And so I thought, well, can we conclude that the reason there are no very few abortions in prison, can we conclude that it's because of these policies? And the answer is no. We can't conclude that, right? That my study wasn't designed for that. This is one of my favorite examples of how quantitative research is hypothesis generating for qualitative research. I'm a qualitative researcher at heart as an anthropologist, and I've heard some people say the opposite. Oh, well, qualitative research, the only point of it is just to create study, so we can design RCTs to answer the real questions. But in this case, we can't understand why there's so few abortions in prisons just by studying policies or the numbers. And so we conducted a qualitative study of 38 pregnant individuals in prison and currently in prison and jail in 2 states, one with abortion that was abortion supportive and one that was abortion restrictive. And this was kind of like, okay, this is maybe the turnaway study, and I'm going to see, if we can follow them long term. But I want to see first just what happens, and are there people who are being denied abortions? And we did find a fefew people who tried to get abortions and were told, oh, we don't do that here, even though their written policy said yes, or no, it's not allowed only in certain circumstances, or, oh, you shouldn't have an abortion, children are blessings. So there were definitely people who were overtly prevented. Some people tried to get abortions, but the bureaucracy of the system and it takes a long time to see a provider, or they had court proceedings that overlapped or conflicted with their abortion appointment, and they wanted to get out of jail or prison. So there were some bureaucratic barriers as well. But what was, I think, most striking and surprising for me was that most of the people we interviewed, they just casually assumed that they didn't have a right to abortion. One woman in the restrictive state said, I just gave up trying to get an abortion, and I thought maybe this pregnancy might be my punishment. Another said in the supportive state said, oh, I didn't think you could get an abortion here because when you're at the Department of Corrections, you can't because you're the state's property. And she said this, so I can still hear it in my head. Like she was just so nonchalant about it. And then there were people like this woman who said, you know, it's horrible. This was part of a longer narrative where she was saying it's horrible being pregnant in jail. You can't eat when you want to. It's just so stressful. The baby gets treated like an inmate. I used to want the baby, but now I don't. And she had tried to get an abortion and was prevented. But then she said, kind of heartbreakingly, okay, now I'm going to have this baby, but are they going to let you hold your baby? And so what these data showed us is that incarceration in pregnancy, it violates all the core tenets of reproductive justice: the right not to have children, the right to have children, the right to safe birth conditions and to make autonomous decisions, and the right to parent and raise your children in safety. And it violates all of those in one pregnancy, And it's hard to ignore now, or it's hard not to wonder, well, what impact is the Dobbs decision and abortion restrictions? What impacts will those have on the health outcomes of incarcerated people who have categorically no option to travel out of state for abortion? And we know that this is an issue of so many things, including maternal morbidity and mortality. Research that has been done in the broader community has shown us this, that abortion restrictions harm pregnant, capable people and increase the risk of maternal morbidity and mortality. So now I want to come back to some of those graphs and demographic overlaps and mental health conditions overlaps that we've talked about. So as we think about this, I want us to keep in mind that this is not a simple story about risk factors and institutional violence and prisons and jails always being harmful places. It's more nuanced than that. And to share a little bit of that, I want to honor the words of a woman whom I call Evelyn, whom I came to know in my time here in San Francisco through my ethnographic research and time at the San Francisco jail. And Evelyn told me in her third trimester when she was in jail, she said, you know, everyone says I got arrested, but I got rescued. I was so sick, I didn't want to get high no more. I just wanted to be in jail where I knew that I could eat, I could sleep, and then even if it's not the best of medical care, I was going to get some type of care. So it's tricky. It's, you know, no one wants to go to jail, right? It's a place full of isolation and violence and harm. And yet Evelyn felt like, you know, it's better than my dangerous life on the street in some ways, and I can get prenatal care. You know, and it's variable. There are some places where prenatal care is extremely dangerous and harmful and neglectful, but it's just to say that it's complicated. Tragically, 6 years later, Evelyn died a day after giving birth to twins. She died likely of peripartum cardiomyopathy. She had been in jail maybe a few times in that pregnancy. She had been to triage many times and had gotten compassionate care from providers and social workers. But ultimately, the precarity of her life, the trauma that she suffered as a child and as an adult was just too much. And she died after giving birth to her 6th and 7th children. Evelyn was a Black woman who now is part of the statistics of these inequalities and inequities in maternal mortality and in mass incarceration. Would it have saved Evelyn to go to jail more for the entirety of her pregnancy? Hard to know, unlikely. But it should urge us to think about these connections as urgent. And this is not, although this has become my career niche, this issue is not a niche issue. This is something that we are all implicated in. And we absolutely have to think about these connections between incarceration and maternal mortality, and that being part of the bigger story. So what are some of the other connections between incarceration during the perinatal period and maternal mortality? I've already talked about the mental health issues. But incarcerated women have higher rates of chronic medical conditions of asthma, diabetes, hypertension, even before pregnancy. We've talked about the variable access to prenatal care, the highly traumatizing conditions, and even for people, especially for people who have opioid use disorder, we all know the standard of care is access to methadone and buprenorphine, and that there are risks to withdrawal in pregnancy, especially the risk of fatal overdose. And yet, in my research with prisons and then a national survey of over 800 jails that we conducted, we found that this very obvious, longstanding standard of care of access to MOUD in pregnancy is not consistently available. Only 18% of jails in this country made both methadone and buprenorphine available for pregnant individuals to both initiate and continue. And so this should make us think about, okay, people are withdrawing, pregnant people are withdrawing when they're in custody. They've got these medical, high-risk medical conditions. And remember, I said the gatekeepers to them accessing medical care, those gatekeepers are custody officers who are not trained. Oftentimes in some prisons and jails, even the frontline medical staff, licensed vocational nurses, don't have perinatal specific training to appropriately triage. And I've seen cases where custody officers have appropriately called the medical staff. This pregnant woman says she's having some bleeding, and then the nurse will say, put on a pad. Oh, you're not soaking through a pad an hour. You're fine. And then tragically, and this did happen to some collaborators, colleagues of mine in another state just a few weeks ago, they're doulas, where this pregnant individual was having bleeding, was ignored, it wasn't a pad an hour, and she ended up delivering a 22-week fetus in her prison cell. And it was extremely, of course, just horrible, traumatizing, should not have happened. And so this I would call deliberate indifference, which is prohibited by the 8th Amendment in that Estelle versus Gamble case. And so all these things, the increased awareness we're trying to promote in recognizing urgent maternal warning signs, this has to be done in prison and jail settings, but there's just a complete lack of awareness and knowledge. So my team is working with some prisons and jails across the country to try to use these tools, this infographic that ACOG and the CDC developed. It's for patients, but I'm using it with custody officers. They're lay people, they need to know this as well. And to know that any amount of vaginal bleeding in pregnancy is dangerous or is something that warrants qualified evaluation. But again, that doesn't always happen. Another gap, sort of unquestioned area is the postpartum period. We know that more than half of pregnancy-related deaths occur postpartum. And in prison and jail settings, there's very limited postpartum care, although we don't know very much. And I myself have been complicit in the lack of production of knowledge about postpartum care, something I'm trying to remedy with future studies now. Even at jails and prisons that provide methadone or buprenorphine in pregnancy, my studies have shown that the vast majority of facilities will stop those medications as soon as someone's no longer pregnant. It's like they only care in as much as they're carrying a fetus, but after that, they don't continue the medications, which puts people at very high risk for fatal overdose. It also is not really an investment in the life of the newborn if you care about them, and even if you don't care about the birthing person. So it's deeply dangerous and problematic. And most prisons and jails don't even screen for postpartum status at intake. So if someone gives birth in custody, they will know about that they'll know they're postpartum, but they don't know, what about someone who maybe gave birth 3 weeks ago? Are they screening for that? And and the need to have heightened awareness for the urgent maternal warning signs, the need to screen for, do you need lactation support? This kind of screening is not consistently happening. So as I mentioned a few minutes ago, I realized, thanks to Diana Green Foster asking me, that no one was collecting data about pregnant individuals. Well, what about deaths and pregnancy-related deaths? Now, I should say in the study, the pregnancy and prison statistics study I described, we did ask about maternal deaths, and there were none. We only were able to ask about maternal deaths as in the first 6 weeks after, because if someone got released, the prison and jail doesn't, they don't know what happens to them. So there's very little data. What we do know, we do know that people who get released from incarceration, those first 2 weeks right after release, are a very dangerous and precarious time, and people have a 13 times greater odds of dying than compared to demographically matched controls, with the most common causes being overdose, homicide and suicide, as well as cardiac complications. And this landmark study that was published in the New England Journal of Medicine in 2007, which is cited incessantly and appropriately about the increased risk of death after release. There's nothing about pregnancy status or postpartum status. The Bureau of Justice Statistics is authorized by Congress to collect data on deaths that occur in custody, but those deaths in custody do not record anything about pregnancy or postpartum status. And again, the National Vital Statistics Program that collects maternal death information, pregnancy-related deaths, does not flag incarceration status. So we really don't know. We don't know. But we can surmise, based on many of the things I've shared with you today, that there is likely a tremendous interaction between exposure to the carceral system during or after pregnancy and before pregnancy, and increased risks of maternal complications and death. Now, there was a recent study, shout out to Dr. Seidman, who is a co-author, linking data in California hospital discharge data and birth certificate data, and looking at incarceration status of the birthing person. And they found no increased risk of birth complications in the birthing person. They did find increased risk of preterm birth and low birth weight, or small for gestational age. However, it was only incarceration status at the time of delivery, not during the perinatal period more broadly. They weren't able to ascertain outcomes beyond the birth hospitalization, and they did not look at mortality. They just looked at morbidity. So there's a lot we don't know. I hope to be able to fill in this gap if the NIH continues to function. I will be starting a new study soon to conduct data linkages, looking at prison admission and release dates, and birth certificate data, death certificate data across 3 states over 20 years, to be able to understand these connections, and then also to do qualitative research with MMRCs on how they do and do not consider exposure to the carceral system in their evaluations of maternal deaths. Now, I know a lot of this is very heavy. It's distressing, it's troubling, and there's nothing I can say to contradict that. But I want you to know there also are some promising strategies. Hope may be too strong of a word, but there are ways to support pregnant and birthing people, and other pregnant capable people behind bars while they are still there. There are a number of doula programs across the country with people who provide support antenatally during birth and postpartum for people who are incarcerated. And I'm working on this with my collaborator at University of Minnesota, the enhanced perinatal programs for people in prison. And doulas have been shown to, not surprisingly, enhance the quality of experiences and be tremendous advocates for pregnant incarcerated people when they're faced with several problematic systems, the hospital system and the prison system. Minnesota passed a law in 2021, the Healthy Start Act, that diverts pregnant sentenced individuals away from incarceration and into the community for their pregnancy and for 12 months postpartum. And then there's a formula. If they still have time to serve, they may have to go back to prison for time, but they at least are with their babies during that first year postpartum. The Department of Justice, Bureau of Justice Statistics, now does collect some pregnancy data. And I say this not to give myself a pat on the back, but just to inspire the residents that you can turn your research into advocacy. But because of my pregnancy and prison statistics study, and that I got the Bureau of Prisons to be involved, that helped to advance legislative advocacy. And basically my study was written into the First Step Act, which is a broad sweeping criminal legal system reform act in 2018. And there's one bullet point that requires collection of data on pregnant people in federal prisons, and it now is reported every year. Medicaid, there are some possibilities there to expand Medicaid. California has approved a waiver so that incarcerated people can get Medicaid coverage for starting 90 days before their release. Senator Ossoff related to a Senate hearing that I was privileged enough to testify at last summer, introduced a bill to standardize and improve data collection and pregnancy care for people in custody. And then also, I would say another essential strategy that must happen alongside all of these strategies to improve conditions now is to reimagine what we are doing as a society, to think and have an abolition mindset and wonder, is this really what we as a society want to do for families, for people in our communities? We can work to, and we should work to improve healthcare for incarcerated people, but we also at the same time need to think about broader ways that we can end the incarceration of pregnant, non-pregnant, birthing people, parents, everyone, and think about alternatives to incarceration. So with that, I'm just going to leave some of these key points up there, but I hope you've started to think more about the connections between mass incarceration and maternal mortality. And this is not, although it is my research niche, it is not a niche issue. And I hope that you will, as you continue on in your careers, whether it's research or whether it's even providing compassionate care to your patients, always question the assumptions and question the familiar notions on which you're practicing and the unexamined ways of thinking upon which what you're doing is based. So thank you very much. I want to thank UCSF, all of you, for inviting me back. It truly is like coming home to the place where I really cultivated my career and my niche. And I also want to thank my research manager, Camille Kramer, who is, I could not do any of this work without her. So thank you very much, and I'd be happy to take any questions. Dr. Rowan.
Dr. Sufrin, I love seeing you here, and I just want to have a couple of questions, but I also just have to say the story of how you found your niche. I repeat that all the time. I actually repeated it at the state tournament
Oh my gosh.
because I think about it. I always think about you and how people fall into things, right? And how when someone gives you an opportunity and you're as skilled and as talented as you are, you just run with it and do amazing things. Okay. Praise aside, I could do that all day for you. But my question is, you are an anthropologist, and I find it really interesting that your research seems to be very epidemiological. And I'm curious how you, where you got the training, how you blend that, how you see your anthropology background contributing to it, and then also how, and then a separate question in terms of how you get your funding, and whether or not you've struggled with that given the kind of area of research that you're engaged in.
Great questions, and I'll paraphrase for those who are listening online. First, Dr. Darney, if you're listening, Dr. Rowan said she tells that story of me finding my niche many times, including at a larger meeting of leadership. And the questions were about a lot of my research seems demographically oriented, and how my training as an anthropologist plays into that, and then also funding. Is that a good paraphrase? Yes. So that's an excellent question, and one I don't think I struggle, but I think about it constantly, and I do feel like an anthropologist. But it's also very prescient because yesterday I had the privilege of meeting with my my dissertation advisor, so it was good to revisit. And she gave me the idea for my next book, which maybe now I will. I never thought I would write a second book, but that's what mentors do. They make you believe that you can do something. And I was telling her about the new project, the data linkage and demography, and like, I'm certainly, I ask my questions as an anthropologist, right? Why do we not know how many pregnant people there are behind bars? Because they've been systematically, categorically erased in our society. And what is the history behind that? What are the political, social, economic forces that have produced that erasure? So I think the anthropology training informs the way I ask the questions. Another way that my the anthropologist in me comes through is in how I write and the different ways that I do. I think in my framing of presenting the data, my introduction and discussion is very anthropologically informed. I cite anthropologists. I cite Black feminist theorists. I cite Foucault. So I think in that, but I also publish in social science and anthropology venues as well. You know, I have, yeah, so I repurpose or reanalyze some of the data and the questions through that lens. And in terms of, you know, and my advisor sort of telling me what my next book is going to be, she's like, you're going to be doing an anthropology of demography. And, oh, you're going to be in it. You're going to be helping to analyze the data and like see how it's produced. And so, so taking that step back as an anthropologist and seeing what's happening, what's not happening, methodologically in the training, I did benefit from the certificate in what is it? The training, clinical training research. So many of you have probably done that. But I wouldn't say it made me a biostatistician or a demographer. And so I work with demographers. I am fortunate on, hopefully if this next project goes through, Allison Gemmel is my demographer, and she's the one who's being quoted in the New York Times about her studies on infant mortality and in Texas since SB8. So I find the right people to collaborate with methodologically. And then I also, the grant I'm talking about, if it gets done, also has a qualitative component. And then lastly, in terms of the funding, grantsmanship, you know, whether you're an anthropologist trying to get funding from NIH or anyone else, you have to know how to package your research questions in a way that gets funding, and then you do the work that you want to do. I'm within, you know, that you're funded to do, but with the methodologies that you know how to do. And so, yes, I collected data about access to opioid use disorder treatment in pregnancy, but I also analyzed it in a way that looks at erasures and those sorts of things. So, so a lot of it is about grantsmanship. Yes.
Thank you so much, Carolyn. This is like so inspiring to see. I was a little medical student when I went into the jail and did some research for you and implemented some of the research questions, and I just like can't say how inspiring. And what I just have a question about in terms of what you, just as an expert in this area about pregnant people in jails and prisons, with the fall of Roe, what do you see happening to people and birthing people who are, or pregnant people who are in federal prison? Because I know there is, until there's a federal ban,
yeah,
but for now it's shifted to the states. But what about federal prisons?
Great. So the question was about abortion bans and people who are in federal prisons. So federal prisons are located in states, right? So they have to abide by the state laws. The Federal Bureau of Prisons, their medical manual or policies and procedures is available online for free, and it has not changed. It still says that people who are incarcerated can access abortion. It's subject to the restrictions of the Hyde Amendment, and as it always has been. But they can't. If they can pay for an abortion, then they will help facilitate an abortion, and that is still there. And when I've looked at the First Step Act reports that have table 2, those 3 lines for pregnancy outcomes, in the last few years, there have been abortions, 2 or 3, but not 0. So they are still happening. And what I suspect is happening, potentially based on some conversations, but also just looking at the numbers, I suspect that what's happening is that when a pregnant person needs an abortion, and let's say the federal prison is in Texas, they relocate them to a different state, a prison in a different state. And they do that all the time for medical treatment. They do it for cancer treatment. They call it, it's not a medical furlough, it's a medical transfer. So I suspect that they're just doing that for abortion. We'll see if that continues, but based on the fact that abortions are still happening, I suspect that's what's happening. I think we have time for maybe one more. Yes, go ahead.
Thank you so much for being here and talking about your work and your research. You're the intern class, and we get to go and spend time at the county jail, and it's really, and you've made such waves here in this community, and it really seems to be exceptional care at San Francisco. So I'm to learn about what it sounds like. I'm wondering about your research in abortion care in incarcerated people, and whether it looked at any coercion. You can argue that, you know, it's coercive to not, obviously it's coercive to not allow someone their right to care, but if people are coerced to have an abortion or to have reproductive care that they do not desire, as far as like tubal ligation, marks, things like that.
Yeah, excellent question. To paraphrase, it was about evidence in my research or potentially others of coercion to abortion care, sterilization, or LARCs. Because there absolutely is that potential, and it actually is a reality. In terms of abortion care, that's not something that I have yet been able to study explicitly as a research question, because it is 11 abortions, right? It's really hard to find those needles in the haystack of people who are pressured to have abortions. At the same time, Evelyn, she told me on several occasions the stories of one of the times she was in jail during a different pregnancy, how the custody officers pressured her to have an abortion, like, stop having babies that you can't take care of. You should have an abortion. And so absolutely, I'm sure that happens for every person who is denied an abortion. Maybe not every, maybe it's not one-to-one, but I feel confident that some people are pressured to have abortions because they're incarcerated. The tubal story is an entire talk, all day workshop. And the short answer is yes, absolutely. And in California, as some of you may be aware, there was a report, an investigative report that showed that from 2006 to 2010, over 100 people were forcibly sterilized without proper consent or without their knowledge. And as a result, in the advocacy of directly impacted folks, California now has a law that prohibits sterilizing procedures for the purposes of contraception. It is still allowed, for treatment of other medical conditions if you need a hysterectomy or gender affirming care. So yes, and California just happens to be where people did this report. I am certain that it happens elsewhere. And in terms of LARC, yes, I am certain it happens elsewhere. And one example is the state of Tennessee, which has some notable laws criminalizing substance use in pregnancy. I learned about 10 years ago about a state program to provide free LARCs in jails and prisons, or maybe it was just county jails. It's great, increasing access to contraception. However, they were not also providing free access to patient-controlled methods and short-acting methods. So the only free methods were LARCs. And I learned that it came out of the budget for preventing substance-exposed pregnancies. Like, it was part of well, we don't want more babies born with drug addiction. Not that babies can be born addicted, but that was their logic. And so yes, this is, and relatedly, also in Tennessee, it wasn't part of this program, but there was a county in Tennessee that was offering free Nexplanons, or Implanons actually at the time, free Implanons and free vasectomies to people in their county jail in exchange for 30 days off their jail time. I mean, that's like the definition of coercion. When the ACLU found out, that quickly got dropped. So yes, people who are incarcerated are preventing from having children in all kinds of coercive ways. All right, well, I'm happy to chat with you all at the breaks or beyond, and feel free to reach out to me. Thank you so much. And I'm so excited to hear about all of your research, Chiefs.